Hello everyone, today we will be focusing our attention on the abdominal exam. The objectives for this session are as follows. The student will be able to state the relevant associated symptoms that should be asked in a patient presenting with an abdominal complaint, systematically perform the components of the general abdominal exam including inspection, auscultation, percussion, and palpation, appropriately perform special maneuvers to identify the presence of ascites, Murphy's sign, Ravsing sign, obturator sign, and psoas sign, state the features of different types of abdominal pain, including visceral, parietal, and referred pain, and document the abdominal exam in a patient write-up. There are a lot of things doctors need to consider when a patient presents with an abdominal complaint, such as abdominal pain. You want to start basic and think about the organs in the abdominal cavity or in the retroperitoneum first. I like to start with the GI tract, and I like to start at the top of the GI tract, which would really start at the mouth and esophagus, and I move my way all the way down to the stomach, the small and large intestine, and the rectum. You want to think about the other organs in the abdominal cavity like the liver, the gallbladder, and the pancreas. You also want to think about the urologic system, including the kidney, ureter, and bladder. The gynecologic system, especially in females, including the uterus, fallopian tubes, and ovaries. The musculoskeletal system, the vascular system, so the aorta, the renal arteries, and the iliac arteries, and then other systems including the spleen, okay? So that's all the stuff that's inside the abdomen that you want to think about if a patient comes in with abdominal pain or an abdominal complaint. The other thing you need to think about is all the other things outside of the abdomen that can be causing abdominal pain. So for instance, a patient who is having a heart attack in the inferior or lower portion of their heart might actually present with epigastric or upper abdominal pain. So there can be a cardiac cause for abdominal pain. Likewise, patients who have pneumonia or a clot in the lung like a pulmonary embolus or fluid in the pleural space, they might also present with upper abdominal pain issues. If you have a male patient who has testicular torsion or an infection in the epididymis, sometimes they can present with abdominal pain as well. So the abdominal complaints can be from a lot of different sources, and it's important to know your anatomy and to think broadly. The first step is obviously taking a good history. You always want to obtain the 7 parameters of a symptom. Remember, the associated symptoms help you make a differential diagnosis, and you want to take a top-down approach when thinking about what to ask. So think about from the mouth all the way to the anus, what could possibly be a problem with the GI tract. And things might include swallowing difficulties, loss of appetite, reflux symptoms, including a sour taste in the mouth or a dry cough, abdominal pain, nausea, vomiting, change in bowel habits, constipation, diarrhea, hematochezia or bloody stool, and melena or black stool. You also want to consider other systems besides the GI system, and you might ask additional questions to discern if there's another cause for the abdominal complaint. So you might ask about dysuria, which is painful urination, hematuria, blood in the urine, urinary frequency. That helps you get at whether the abdominal complaint is something in the urologic system. You might also ask about vaginal or penile discharge or menstrual irregularities, which might indicate a problem with the gynecologic system. You also might want to ask about chest pain, cough, shortness of breath, which would get at any cardiopulmonary cause for your abdominal complaint. And obviously don't forget the rest. You need to ask any pertinent past medical or surgical history, medications, allergies, and family and social history. The next step is performing a good physical exam, and I'll give you a demonstration of this at the end of this video. Basically, you want to make sure that the bed is flat, okay? The patient needs to be completely supine. Their entire abdomen needs to be exposed. Even if they're wearing underwear that go up to their umbilicus, you need to ask them to lower them down so that you can see the entire abdomen. You want to make sure that the patient is relaxed, okay? Their arms should be at their side, their mouth should be open. Usually when people exhale, their abdominal muscles relax, and so the exam becomes a lot easier. You can have the knees and hips flexed. You don't have to do this, but that can sometimes relax the belly. And it's also nice if you had patients empty their bladder before you do the abdominal exam. The first part of the physical exam is inspection. You want to look at the abdomen for any scars that might indicate previous surgeries. You want to look at the contour of the abdomen. if you see a protuberant abdomen, possible causes could be a mass, there could be fluid in the abdomen, there could be a lot of air or gas in the bowels, or it could just be abdominal fat. You also want to look for rashes or abnormal skin lesions and any abnormal pulsations in the abdomen. The abdomen is typically broken up into 4 quadrants: right upper quadrant, right lower quadrant, left upper quadrant, and left lower quadrant. You can also divide the center of the abdomen up into 3 additional categories, the most upper being the epigastric area, the center being the umbilical area, and the lower center portion being the hypogastric or suprapubic area. Scars are really important because they tell you about previous surgeries a patient might have forgotten to mention in the history. A lot of these scars are sort of going by the wayside. Now that we have laparoscopic surgeries, you'll often just see small areas where the operator inserted the cameras and other instruments. But some patients who had open procedures or surgeries a long time ago might have these scars. The next part of the exam is auscultation. You want to use the diaphragm to auscultate bowel sounds. Bowel sounds are transmitted and best heard in the right lower quadrant due to the location of the ileocecal valve. You're going to hear clicks or gurgles, usually hear about 5 to 34 per minute. You can classify bowel sounds as absent if you don't hear them after listening for a minute, hypoactive, normoactive, or hyperactive, and that can indicate different types of abdominal pathologies. You also want to listen to vascular sounds, and you use the bell for this. Bruit is a sound or a murmur heard in a vessel as a result of increased turbulence. Okay, you can hear bruits in the aortic area, and I'll show you a picture on the next slide of that, the renal arteries and the femoral arteries. So these are just the locations of where you might hear the possible bruits that I mentioned in the previous slide. The next step would be percussion. And this is probably best demonstrated in my video with the patient instructor. But you're using percussion to assess the size of the liver and the spleen. You might use it to detect the presence of ascites and also the distribution of gas. We usually describe the abdomen percussion as tympanic because there's gas inside the bowels. If you detect dullness, it could indicate fluid, mass, or the fact that you're over a solid organ. When you're percussing the liver, you want to percuss in the midclavicular line. You want to start above on the chest wall, and you should really hear lung resonance until you hit the liver top edge. You want to keep going down until you hear the tympani of bowel gas. A normal liver span in the midclavicular line is 6 to 12 centimeters. Percussion of the spleen is a little more challenging. You want to percuss the left lower anterior chest wall between lung resonance above the costal margin. You want to percuss along the route suggested by the arrows. A normal spleen is not dull until you're really below the mid-axillary line. There's a moderate accuracy in detecting splenomegaly, about 60 to 80% sensitivity, and the specificity for spleen percussion is about 72 to 94%. The percussion of the spleen is challenging because it can be compromised by fluid or solids in the stomach or the colon. Ascites is fluid, is really the presence of fluid in the peritoneal cavity. You might think about ascites in a patient who has a protuberant abdomen with bulging flanks, as seen in the diagram on the left-hand side. Basically, fluid sinks with gravity. So the gas-filled loops of bowel would be up at the center where it says tympani, and the fluid sort of rests in the flank area and the lower part of the abdomen. That's where you would get dullness. So the gas-filled loops of bowel like to really float to the top. So that accounts for the tympani up in the center of the abdomen. So after mapping out the borders of tympani and dullness, you want to ask the patient to turn on one side and percuss and mark the borders again. In a person without ascites, the borders between tympani and dullness should remain relatively constant. Another test to detect ascites is and you need either to have the patient help you with this or an assistant. So the assistant would press the edge of both hands firmly down the midline of the abdomen. This pressure helps to stop transmission of a wave through fat. You, the examiner, would tap one flank sharply with your fingertips and try to feel the opposite flank for an impulse transmitted through fluid. This sign is often negative until ascites is really obvious, and sometimes it's positive in people without ascites, so it's not a very good test. The next part of your examination would be the superficial or gentle palpation. You're doing this very lightly. It's very superficial, about 1 centimeter depth. It's a one-handed technique. You want to localize areas needing greater attention, and you always start away from the area of pain. So if a person came in with right upper quadrant pain, you might start in the left lower quadrant and move your way towards the right upper quadrant. You want to always watch the patient for any change of facial expressions or grimacing. Guarding can either be voluntary or involuntary. Okay, voluntary guarding is a patient sort of clenching their abdominal muscles because they know it's going to hurt them if you touch the area, so they're a little apprehensive about it. What you can do is have the patient try to do open mouth breathing. The abdominal muscles should usually relax during exhalation. Involuntary guarding will not relax during exhalation. It's a protective spasm of the abdominal muscles, okay? And it would indicate that there is a problem in the peritoneal space or inflammation in the peritoneum. Deep palpation is a two-handed technique. It's required to delineate any masses. You want to use the palmar surface of your fingers. Again, you survey away from the area of pain first and move towards the area of pain. Rebound tenderness is tenderness elicited or increased with rapid withdrawal of the examiner's hands. So you would press in with both hands and really depress the peritoneum, and then you want to quickly remove your hands, and pain with the removal of your hands is considered positive for rebound tenderness. The next part of the examination of the abdomen is palpation of the organs. The first one we'll do is the liver. You want to put one hand under the right flank and your other hand should be in the right upper quadrant. You ask the patient to take a deep breath, which brings the liver down. Then they exhale and you get your hand in position. You have them take another deep breath in, and again at that point you're feeling the liver edge during inspiration. It's normal to feel the liver edge about 3 centimeters below the right costal margin. If a patient is obese, you might want to use the hooking technique. This really involves sort of wrapping your fingers underneath the right costal margin. And again, you're going to have the patient take a deep breath in and exhale, and that gets you into a deep sort of position to feel the liver, and then you have them take another deep breath in, and the edge of the liver should hit the bottom of your fingertips. And that's another technique you can use. Palpation of the spleen is difficult because of its position. You want to make sure that the patient is supine. You want to put one of your hands underneath the left flank of the patient, and the other hand should be pressing under the left costal margin. You want to have the patient take a deep breath in and then exhale, get your hands in position, and have them take another deep breath in to see if you can feel the spleen. It is normal not to feel the spleen in a patient. Palpation of the kidney. So when you're checking for palpation of the kidney, really we call this costovertebral angle tenderness. And it's one of the tests we do if we think a patient has an infection in the kidney. So you want to place one hand over the costal margin posteriorly on their back. Usually this is over the 11th or 12th rib. And then with the other hand, you're doing a tapping sensation. And if a patient has an infection in the kidney, they typically would have a lot of tenderness when you did this. The other palpation you can do is palpation of the aorta. Remember, the aorta bifurcates at the umbilicus, so you want to feel slightly above and to the left. You want to do one side at a time. What you're doing is you're taking your index and third finger, even your fourth finger, and palpating along until you feel a pulsation against your fingers. You then want to go on the other side and do the same exact thing. The distance between your fingers is the width of the aorta. A normal aorta is less than 2.5 centimeters wide. The sensitivity of this test really increases as the size of the aorta increases, and the sensitivity is much lower in obese patients. It has a very high positive likelihood ratio, so it's actually a very good test to do. Remember to use your history to focus your physical. You may need to do heart, lung, genitourinary, or rectal exams depending on your history. I'm not going to go into those in detail, but I just wanted to put this little slide in to remind you of that. There are several categories of abdominal pain: visceral pain, parietal pain, and referred pain, and we're going to go through each one. So the first one we'll discuss is visceral abdominal pain. Visceral abdominal pain occurs with distended, stretched, or unusually forceful contraction of a hollow organ against its capsule. It's often very vague and difficult to localize. It's typically located in the midline at levels associated with the involved organ. It's usually gnawing, burning, crampy, or achy, so you might find this on your history. And patients usually appear restless on exam. Parietal abdominal pain is caused by inflammation of the parietal peritoneum. Pain's usually steady and aching. It tends to be more severe than visceral pain, and it's precisely localized over the involved structure. Discomfort is typically aggravated by movement, coughing, and patients typically have rebound tenderness. Patient is usually lying very still because they don't want to move at all. Parietal pain, these are just different examples to illustrate what I just discussed. Slide 27. Referred abdominal pain is pain felt in more distant sites with same spinal level of innervation as the affected organ. Referred pain usually develops after presenting pain has become intense, and thus the pain seems to travel or radiate from the initial site. Pain may actually originate from the chest, the spine, the pelvis, and radiate to the abdomen, such as the examples I gave earlier in this talk of the inferior myocardial infarction or testicular torsion. There are a couple of special tests that we want you to know about. One such test, if you're considering that a patient has appendicitis or inflammation of the appendix, would be to locate McBurney's point, which is located a third of the distance along the line from the anterior superior iliac spine to the umbilicus. Tenderness in this area is often associated with appendicitis. Another test you could do if you're considering appendicitis in your differential diagnosis would be Rovsing sign. Rovsing sign is positive if pressure on the left lower quadrant causes pain to increase on the right lower quadrant. It's actually referred rebound tenderness. So you're pressing on the left lower quadrant and then releasing your hand, and pain on the right lower quadrant when you do that is considered a positive Rovsing sign. The sensitivity of this test is anywhere from 7 to 68%, and the specificity 58 to 96%. It has a positive likelihood ratio of 2.3 and a negative likelihood ratio of 0.8. There are two other tests you can do for appendicitis. One would be the obturator sign, where you have the patient flex and internally rotate the hip. This is done passively. A positive test would be pain in the right lower quadrant. There's also psoas sign. You ask the patient to actively flex their hip, and usually you place your hand right above their knee, and they're pressing up against your hand. A positive test would be pain in the right lower quadrant. The sensitivity of psoas sign is about 16%, and the specificity is 95%. So it has a good positive likelihood ratio of 2.4 and not a very good likelihood ratio of 0.9. The obturator has not been studied independently, so I can't give you statistics for that test. Really, there is no test that is going to effectively rule out appendicitis on physical exam. So you really need to take a good history, do your physical exam, and take all factors into account when you're thinking about appendicitis. There's no test that I can teach you that's just going to just rule out appendicitis. If you're considering that a patient might have acute cholecystitis or infection in the gallbladder, Murphy sign might be a test that you do. What you want to do is hook your fingers under the right lateral costal margin and have the patient take a deep breath. A sudden stop of inspiration due to pain is considered a positive Murphy sign. This test has a sensitivity of 65% and a specificity of about 87%. Likelihood ratio, a positive likelihood ratio of 2.8 and a negative likelihood ratio of 0.5. In summary, you want to prepare the patient appropriately. So they should be lying on a flat table, supine, with their arms at their side and having an empty bladder. You want to do inspection, auscultation of bowel sounds and bruits, palpate superficially to detect any guarding, which could be voluntary or involuntary, and then more deeper to detect any masses or rebound tenderness. Then you want to examine the specific organs like the liver, the spleen, the aorta, and you might do specific maneuvers if your history pointed toward a specific cause like appendicitis or acute cholecystitis. Here's an example of charting. Remember to record your findings in the same systematic way you examine the patient so you don't forget anything. You might write in your chart that the abdomen is flat, symmetric with no masses, that the skin is smooth without scars or lesions, so that's the inspection. The bowel sounds are normal active and there's no renal or femoral bruits. That would be your auscultation. Next would be percussion. Tympany predominates in all four quadrants. The liver span is 8 centimeters in the right midclavicular line, and splenic dullness is located at the 10th intercostal space at the left mid-axillary line. The next part would be percussion. The abdomen is soft. There's no organomegaly, meaning the liver and the spleen are normal in size, and there's no guarding or rebound tenderness. The last part would be additional tests that you might have done if you were considering a specific diagnosis. So there you would say negative for Murphy's, Robsing's, obturator, or psoas sign. I hope you found this lecture helpful. Now you'll be able to watch me do the complete abdominal exam. Please contact me, Dr. Keynes, at Keynes. My email is keynes@uchc.edu if you have any additional questions. Thank you.